My name is Claudia, I'm a pediatrician, and I'm going to present you a community-integrated intervention to incorporate psychostimulation into the routine activities of the ITFC of Malakal project in South Sudan. As you well know, psychostimulation is recommended by both WHO and the MSF guideline as a standard care for malnourished children. However, in Malakal project, its implementation was lacking due to several factors. The main challenges were the lack of proper space and the lack of toys. Regarding the space, in MSF hospital, we did not have an identified room dedicated to playtime. And regarding the toys, we only had one single box of toys that children needed to share during psychostimulation sessions, because most of our patients did not have toys that could bring from home. And the fact of sharing the toys, of course, led to concerns regarding the cross-infections and restraining the playtime only to the formal activities. So to overcome all of these challenges, we set together the pediatric, mental health, and community engagement team, and we designed a two-pronged intervention. First, we think how to overcome the problem of the lack of toys. And for doing that, we decided to integrate the community. So we recruited 8 female volunteers representing of each ethnic groups, and we trained them to craft toys from recycled materials according to the WHO guidelines. It's this kind of toys. The WHO give guidelines on how to craft toys from recycled materials that are safe for the children, stimulating for the sensitive. And the fact that we used local volunteers also made them culturally sensitive. So this is the picture from the first training, and we call this activity the Toy Lab. After the training, they started to meet bi-weekly, twice per month, to craft toys that were later distributed to the hospital. Furthermore, we thought that we could use this forum also for health promotion activities, and so they started to receive health education sessions that were related to malnutrition or female health. So once we overcame the problem of the toys, we thought of how to integrate the psychostimulation in the routine flow of activities of the ITFC. For doing so, we identified a specific room for psychostimulation, we renovated it, we gave specific training for counselors, and we increased the number of sessions, including in-room sessions for unstable patients who could not leave the room, for example, babies who were on oxygen. So here you can see the sessions in the new psychostimulation room. So after our intervention, we were able to provide 4 psychostimulation sessions per week that included bedside sessions for unstable patients. And during the time that the toy lab were functioning, they carried out a regular session, and we were able to provide 1 toy per every child admitted in the ITFC. And this allowed mothers to encourage playtime even outside the formal sessions. The main challenge that we faced was that we had some tensions in the community regarding the selection of the volunteers, and for this we decided to rotate the group every 4 months. And unfortunately, in April 2025, the activity was stopped due to rising instability in Malakal. But other colleagues who are now in the project are trying to restart it, so hopefully it will be restarted soon. Overall, we thought that the Toy Lab model offered a scalable approach for integrated psychostimulation in low-resource and high-risk settings like Malakal, and the activity was very positively received by the community, fostering women's empowerment, interethnic cohesion, and community involvement in patient care. We also found that the collaboration between pediatric, mental health, and community engagement team was really effective. And finally, we think that the one child and one toy approach reduces the risk of cross-infections and enables more playtime. The main limitation for our work, it was that we did not have the time to perform a formal evaluation because, as I said, the activity was stopped in April 2025. So we think that a formal evaluation would be useful if the activity is restarted to evaluate both social and clinical outcomes. And also, it would be nice to try to reproduce this model in other settings. So thank you for listening, and if you have any comments or questions, you can reach out to me. My personal email address is claudia.solito.90@gmail.com. Thank you very much, and goodbye.
You